Okay, so as promised, we're continuing the presentation for the renal system part two from slide 40, and we're talking about obstructive bladder syndrome, OAB. Once again, nothing's going to surprise you. It's very simple ideas to remember. Um, so this is a syndrome of urgency, meaning that it's associated with the lack of time between when you are alerted or given, the signals that you inform that you really need to go and between actually going. So there's very little time, and that's the urgency. So you have to go to the bathroom right now. You can't hold it and it's going down, and you better find a bathroom. And a lot of people suffer from it in old age. It's actually quite common, and it can be fixed. There's ways to fix it. One of them, by the way, is Botox. So Botox is not only used for facial sculpturing; it can also help with this. Um, and it's usually due to bladder overactivity with the urgency to urinate, and it's you have the lack of control of how voluntary it is, um, and the bladder is just contracting on its own with a bit of a lack of control during its feeling. So you know uh, it's contracting. There's no signs, no warning, and you just have to go. Uh, then we can see that this could, of course, affect your day-to-day life and how you plan your life. People don't go to malls without surveilling online where every bathroom is. They have to know where the nearest bathroom is at any time. Some use pads. Some need to have additional clothing with them and baby wipes. And of course, this could lead to uh, depression. Obviously, it's going to decrease your quality of life. You might not want to go out in the open and be social because you're going to urinate yourself, and that can cause social isolation. And then, it can cause you to slip and fall. It can cause infections because you're urinating multiple times and you are um, exposing the area to the environment more than usual, which is one of the mechanisms that can cause infections. Then we can talk about urine flow obstruction, UFO, right? Um, Obviously, we're going downwards in the system. In this case, when we look about the tracks, and we're going down to the pelvic area to where it's supposed to leave the body. So we're post, if you look at the system at the direction from going from up to down, and as we talked about before, we're talking about beyond the bladder already. So you can see that we can have a urethral stricture or prostatic enlargement in men, and then a pelvic organ prolapse in women. Um, so symptoms, as you can see, is frequent daytime voiding, um, every 2 hours when you're awake, and even more. Then during the night, you might have a poor force to the stream, meaning you don't have enough power to produce that clear stream that helps urinate normally. You might have stoppage of the stream in between, um, bothersome urgency. Once again, no warning signs. You just have to go, and it's a few seconds, by the way, not minutes, seconds before you go. Uh, um, then you might have a problem beginning urination because you don't have enough strength to produce that first push, so to speak, pressure in order to urinate. And this may be caused because of a narrowing of the lumen, because of infection, injury, uh, surgery that you might have undergone, scarring that from the inside decreases the caliber of the tract of the pipe, right, of the vessel. Um, let's see what else can we talk about. The closer uh, the location inwards or upwards when you look anatomically, the more severe the symptoms are going to be, and the greater and longer the obstruction and the stricture is going to be. What else? Then we might have a hernia. Obviously, hernia is a more advanced situation and worse situation than anything prior. Then you might, if it's not treated, it might affect the nervous system from the inside out. And now you have, as we said before, the combination of neurologic injury and damage as well. Then you might have an anatomical difference or change occurred that occurs by collagen fibers being deposited within the smooth muscles, and that of course changes the effectiveness and the ability and the function of the muscles that help urinate. It will decrease or increase accordingly, mostly increase the strength of the concentration, but at the same time you will lose elasticity. I'd like to explain that. Very simple. Collagen is very tough. It's very strong. So with every construction, you now have a structure that is stronger in its built. So it's going to increase the strength of the contraction, but at the same time, collagen is not as elastic. So you're going to lose elasticity at the same time. So every time the bladder contracts, it's going to produce greater power on the one hand, greater pressure, but on the other hand, its compliance, its ability to enlarge and accumulate fluids is lessened. So you're peeing more, but harder. Okay. Um, okay. I suggest that you read about renal tumors. Although we've talked about cancer, there's nothing really new here. The idea is a mechanical mass that's going to affect gradients and the area mechanically. So that's the next two slides. I didn't think there was a need to elaborate on that. Tumors are part of every system, and the principles are the same. Then we can talk about, obviously, we can take the situation to an immune situation clinically, to a UTI. So basically, it's the same tract, only that has an infection. I'm not going to go over that too much because we've talked about this enough times. All you have to do is integrate the information from the immune system. So we have an infection, and we, in this case, are dealing with bacteria, most likely from the epithelium and the gut flora. We've talked about the flora. Can be multiple reasons of infections. Obviously, you have two options. This to remind you, the threat is either coming from the inside, meaning that friendly bacteria have turned on you, so to speak, and we've talked about that, or that it reached from the outside. And when we're talking about the urinary tracts, these are prime places to have infections because they have an outlet, literally, they have a connection, literally, physically, with the environment. And if something can go out, something might come in. So that's part of the deal. So this is not a shouldn't surprise you in any kind of way. Um, then we can talk about acute cystitis, TIS at the end, the suffix for inflammation. We're talking about an inflammation of the bladder uh, with different symptoms according to whatever is causing this inflammation. Um, of course, if you have hemorrhage, as always, you have a blood leak. The question is it local or systemic? The second one is worse. Any hemorrhage is always worse than with non-hemorrhage. Then, if you have already pus and any kind of exudates, that is an estimation of the time that has passed, because pus accumulates with time. Pus usually includes dead skin and dead cells and all kinds of um, component substances removed and accumulated. That's what makes it so foul. Usually it smells. And so hemorrhage is bad, pus uh, worse, pus with blood by far the worst. Then, of course, we have parts within. We have a mucus within the bladder that has a protective aspect to it. When that starts peeling off, uh, it exposes the bladder to infections and to worse cell injury. You can see that it can go to complete necrosis of the bladder wall. Um, Obviously, infection might be accommodated by fever. Nothing new here. When you have low immunity, because the worse the infection, obviously, the lower the immunity in the area, parasites might take uh, um, advantage of it, right? So nothing new about that. And of course, uh, you're causing all the right conditions for cancer to evolve. What else? You have the symptoms. Nothing out of the urine of the normal here, ordinary here. You have cloudy urine that might be a symptom, although it's not the only um, symptom for this condition. Then you can see that we're moving on. First of all, we're talking about painful bladder. Pain is always worse than non-pain, at least at first. It means that the pressure over nerves that indicate and can sense, pain is greater. And you can see that we're going towards intestinal ascites. So this could include non-bacterial inflammation, and then the infectious ascites. So those are two different kinds. And then we have the interstitial ascites. You see the symptoms include frequency, so you're urinating quite a lot. Urgency, meaning it has to happen right now. You see dysuria, the change. How should I best define it? The change in the volume and the flow of it. You have nocturia, the need uh, um, to pee a lot at night. You can see that when you look at the urine itself, it has bacteria in it. It's idiopathic, right? And then you see that the unique signs is that it's most common in women aged 20 to 30 years. Of course, any person that is immunocompromised has a better chance, or worse chance in this case, of getting it. Let's see things that we haven't talked about before with the immune system. You see that's idiopathic. That's about it for that portion of the things. The rest was talked about during the immune system. Advancing to slide 69, uh, we're talking about an infection in both the upper urinary tracts from both sides, um, most likely originating from an obstruction and reflux of urine from the bladder, meaning we're going upwards. Um, you can see that it originates in this case a lot from medical equipment not being highly hygienic or taken care of, especially during surgery. Um, I don't care um, about you knowing exactly the name of bacteria that does this, but you should know that these bacteria create a lot of ammonia, and ammonia um, changes the pH, elevates the pH of urine, and is also dangerous at high levels, and it helps create kidney stones. So everything that we've talked about um, is occurring, right? Then the infection can always reach the bloodstream, which is a bad idea because now you have a systematic problem. Severe infections lead to severe cell death, which is one of the main components of pus. So pus is going to accumulate. It's most likely going to be accumulated in designated areas, and that will lead to the formation of abscesses, which we'll talk about when we talk about dermatology. But abscesses basically are sacs that secrete oil and accumulate dead skin and dead cells and all kinds of substances, and it becomes that pus that we're, fluid pus. So the worse it is, the more fluid it is, and the more smelly it is, and then the worse it is as well. So that's about that. So we talked about the acute condition. Then obviously the chronic one means that there is a chronic imbalance in the system. Um, the system is not able to balance itself. It stays around for a long time, and then obviously it might spread because it's not treated, right? Because it's chronic, and then it might reoccur because it's chronic, and the symptoms might get worse because all the components of the infection have time to advance and become worse. So everything from the severity of the infection to the extent of the damage, the extent of the obstruction gets worse. Um, what else? That's the main points about that. Then we can go to the glomerulus specifically and look at problems with that. Obviously, that's very located and very specific to one area of the renal system. And then we can talk about GN. Once again, inflammation, infection, which obviously will have inflammation of the glomerulus. And you'll see that we're going to move around, so to speak, anatomically between different areas of it that will affect different aspects of function. You can see that the causes are not new. Primary injury, meaning it's originating from the inside. Then you have the wrong immune responses, lack of sufficient oxygen, right? Free radicals, drugs, toxin, vascular disorders, and infection. Basically, it's a reminder of the list of what can cause cell injury, in this case in the renal system, but you've met it before. Then you see that you have secondary infection or injury that obviously originates from the outside. I just want you to look and see that diabetes mellitus is in there, of course. Um, how wouldn't it be? The worst, one of the worst diseases in the world. Um, the rest is kind of basic. I'm not going to go over this again, just read through it, but it's really basic mechanisms of cell injury. Obviously, one of the outcomes is the change to the membrane, and changes to membrane immediately correspond to changes in functions. What else? The rest is basic. It really is. Notice the unique outcomes and symptoms, as your brain should be already focused on looking for those. You know that the severity depends on the size of the area that is affected, the number of cells affected, location, duration, and type of immunosuppression or injury. Um, what else? I'm trying to see something that is substantially new to you that you can't read and say, hey, I already know this. Just apply it to the renal system. Um, okay, perhaps focusing on slide 84. You see in the unique symptoms that we're talking about hematuria, meaning that you have blood cells, or what we call RBC, red blood cell casts, in your urine with an exceeding of 3 to 5 grams per day of protein, which we said we don't want to have that, and then albumin as the major protein. Just a reminder that albumin is a cardinal, is a major central protein in the blood tissue. It's the protein that is the most common and makes up to 50% of all proteins in the blood. And when you see that in your urine, that is not a good place to be in. Then obviously blood tends to be a bit more red. So if you have it in urine, that should be white or can be yellow. It's going to color it towards kind of a smoky brown color. Of course, anything in the urine, if you remember, that goes, starts becoming orange, brownish, the darker it is, the faster you need to get to the hospital. And it's better to get to the hospital even if it was unneeded than not to get to the hospital when it's needed, obviously, right? But people still stay at home until it's too late. Obviously, any chronic bleeding is a bad symptom to have. What else? Trying to see. We're still talking about blood sediments and proteins that should not be there, exactly like lipids and blood. So all of those are not supposed to be there, and they give you an indication to what's going on and what is not working. You don't need to know diagnosis and treatment. Then, of course, why not talk about how diabetes can influence the nephron? So we're talking about DN. We're talking about how diabetes is going to influence the function of the renal system and the nephron specifically. Here's the bottom line. Glucose is horrible. It's horrible. In this case, it's horrible for two reasons. You know what? Three reasons, if I think about it. Mainly, not only, by the way. There's multiple ways that diabetes can mess with you, so to speak. One, glucose tends to absorb water. Okay, so it takes water out of the system, and water is needed to function mechanically and chemically. Number two, proteins are coated by glucose. So in this case, you're coating the chances of a protein within the renal system or the nephron to be coated and lose function is increased. And then, of course, glucose influences for the worst. In this case, when it's in elevated concentrations or levels, it influences the nerves, the neural system. So this is not going into a very nice place. Uh, Once again, you're talking about diabetes that is influencing the renal system. Everything that we've learned about diabetes is going to affect the renal system. Once again, cell injury, scarring, loss of function. Um, and if it's not treated, and since diabetes can be chronic, you're going to have chronic kidney disease. Very, very simple. Okay, we are on slide 89 talking about lupus nephritis. Um, so we're talking about um, immune complexes, in this case, generated for all the wrong reasons. We have an immunoresponse causing complex complexes with dispositions in the glomerulus. It usually has a genetic background to it, and it's gonna um, activate those immune cascades that we've learned about, um, damaging the glomerular membrane um, and causing expansion of cells and the loss of function. So, bottom line, inherited uh, autoimmune disorder causing chronic inflammation of the glomerulus. Okay. Then we can talk about Berger disease. It's the idiopathic acute form of glomerular infection. Um, you can see that we have the binding of two kind of molecules, and in this case, abnormal glycosylated. Once again, glucose binding to a protein, losing function. IJA1 and other molecules that are binding to the mesangial cells, um, and that leads to the flourishing, so to speak. In this case, it's going to have a negative implication of oxidants and proteases, and it's going to start influencing function once again. What else? You can see that within 48 hours, we have gross microscopic hematuria, meaning that we have very small spots of blood in the urine, and then it will start going upwards towards the GI tract and the respiratory system. So it can reach the upper area of the body, obviously, which is a bad thing. Talking about MGN, we have disposition of antibodies that express their antigens within the membrane. Once again, you're taking one of the most functional structures of the cell. Now you have disposition of immune factors in it, It causes an inflammatory response that is in response to injury, but also accelerates injury right now. Um, it increases, it changes the formation of the membrane. In this case, it's increasing the permeability of the membrane on the one hand. Then it leads to the thickening or the scarring, um, and that is going to affect the cells within the nephron, their ability to filtrate. So now you have a functional problem causing increased filtration in this case. Then you have the same idea, just that it's rapid. So obviously this is the severe form of MGN. So when we talk about RPGN compared to MGN, we're talking about the that it's occurring way faster, okay? And then usually it has more severe symptoms. So not much to add here. What else? Now we can talk about basement membrane disease. So every cell, so to speak, has a basement membrane that differentiates it more from a mechanical aspect. The basement, as it's called, is what holds the whole house, right? So if you have a problem at your basis, everything above it is going to have a problem. So this is the autoimmune form of RPGN, meaning that the immune system is attacking the body itself, right? That's basically it. I'm going to stop here, and we're going to continue from slide 100 with CGN. Stay tuned.